next session, which is about obstetric anesthesia. Managing the mother and then the fetus simultaneously is both risky and rewarding. So in-depth knowledge of obstetric anesthesia is necessary. Let us now move on to the next session on obstetric anesthesia. I invite on the dais our chairpersons for the session, Dr. Usha Devi Madam, who has basic degree and post-graduation in anesthesiology from Mysore Medical College. She has worked as a teacher in various capacities in the Department of Anesthesia in Mysore Medical College and Adi Chuncharangiri Medical College, Bellur. She is an active member of ISA Mysore and has served as secretary and president of ISA. She is an author of several published papers. She was involved in the development of the surgical ICU of KR Hospital and spent 2-hour extension of honorary service granted at KR Hospital MMCRI and is as in charge of ICU and took part in developing ICU. Next chairperson is Dr. Karthik GS. He is a professor, Department of Anesthesia and Critical Care, Rajarajeshwari Medical College, Bangalore. He is a member of ISA and Indian Society of Critical Care Medicine. He has 4 international and 15 national publications to his credit. He was the organizing secretary for CME on inhaled anesthesia delivery systems conducted in 2021 at Rajarajeshwari Medical College Hospital, Bangalore. Obstetric anesthesia, neuroanesthesia, pediatric anesthesia, critical care, and ultrasound guided regional nerve blocks. Over to the chairpersons to start the next session.
I thank the organizers for giving us this opportunity to be the chairpersons. I invite the first speaker, Dr. Sreepriya. Dr. Sreepriya is additional professor at AIIMS Mangalagiri. Her areas of interest include regional anesthesia, anesthesia machine, safety in anesthesia practice, airway and palliative care. She has numerous publications in national and international to her credit. She is a resource person she was a resource person for 35 conferences, workshops and CME, and she is a peer review. She reviews the Indian Journal of Anesthesia. She has authored chapters on anesthesia machine and its components, and also anesthetic breathing systems for the textbook, Understanding Anesthesia Equipment and Procedures. I welcome you, ma'am. Over to you.
A very good morning to one and all present here. At the outset, I thank the organizers for giving me this wonderful opportunity to be here today. The topic that's been given to me is gestational changes and the anesthetic implications. And this will be the outline of my lecture. What are the physiological changes occurring in pregnancy? Why do they occur? How do these changes progress over the course of pregnancy? And what are the implications for us as anesthesiologists? So primarily, the maternal changes that are occurring during pregnancy are an adaptation to meet the metabolic demands of the growing fetus, as well as the blood loss that occurs during delivery. They are triggered by the hormonal changes that occur during pregnancy. The estrogen, progesterone, relaxin, prolactin, all this HPL, all increase during pregnancy. Along with this, there's also an increase in the sympathetic activity. So they all begin by around 4 to 5 weeks of pregnancy. But when we look at when these resolve, they do not resolve abruptly or simultaneously following delivery. A few of these changes resolve by around 16 hours, but a few may last for up to 12 weeks postpartum. So it is very important that we understand that these changes are persistent when we are taking up these patients in this postpartum period. One very obvious change is a gain in body weight. An average body weight gain of 12 kg is considered normal, of which 6 kg comes from the uterus and its contents, namely the amniotic fluid, the fetus, and the placenta. There's a 2-liter increase in blood volume, and the fat and the protein add another 4 kgs. The implication for us is that the pharmacokinetic of drugs depend on the blood volume, and the volume of distribution depends on the interstitial fluid volume as well as the fat compartment. So all this volume of distribution can be increased, and therefore the half-life of drugs is prolonged. So fluid retention also causes mucosal edema and capillary engorgement in the upper airways. This predisposes the upper airway to trauma, bleeding and obstruction. So all airway manipulations, be it the laryngoscopy, intubation, insertion of oropharyngeal airway or suctioning, in all these we should be extremely very gentle. And mucosal edema also causes decrease in diameter of the trachea. Therefore we should have a 6 and 6.5 mm internal diameter endotracheal tube always ready in a labor room OT. So the fluid retention and the increase in body weight is going to increase the Malampati score during pregnancy, and it has been shown that there is a 34% increase in the Malampati class 4 airway when the airway was studied at 12 weeks and 38 weeks of pregnancy. Not only this, during the course of labor itself, the Malampati score can go up, not just by 1 grade but even by 2 grades. This is because active pushing is going to increase the venous pressure and thereby the edema. The enlarging uterus has mechanical effects on the musculoskeletal system, respiratory system, cardiovascular, as well as the major intra-abdominal vessels. By 20 weeks, the uterus is of a sufficient size that when a pregnant lady lies supine, it can cause compression of the major abdominal vessels against the vertebral column. There is a near total occlusion of the inferior vena cava as well as a compression and displacement of the aorta. IVC compression means decreased preload to the heart and decreased cardiac output. There is a 10 to 20% decrease in cardiac output when the patient lies supine. And 15% of women manifest hypotension, bradycardia, pallor, nausea, vomiting and sweating when they are made to lie supine. This is called the supine hypotension syndrome. Not only does this affect the mother, but also the fetus is compromised. This is because placental circulation, placental perfusion primarily depends on the arteriovenous pressure difference. The arterial pressure is going to come down because of the decreased cardiac output as well as the aortic compression. On the other hand, the venous pressure increases because of IVC compression. So it is always important. The first take-home message is that we should always transfer all pregnant patients only in the lateral position. This is a period when all monitoring of the mother and the baby is not optimally employed. Under anesthesia, be it general anesthesia or local anesthesia, a lateral tilt of the table or placing a wedge under the right hip is necessary to produce a 15-degree tilt. And if this does not relieve hypotension, we may have to increase it up to 30 degrees. Even manual displacement of the uterus is used to avoid this fetal hypoxia, asphyxia. So, chronic partial vena cava obstruction in the 3rd trimester predisposes to stasis, phlebitis and edema of the lower extremities. The importance of this for us is that we have to differentiate physiological causes of edema from pathological causes. And increasing lordosis means there's going to be a narrowing of the interspinous spaces. Along with this, the spinous process may be difficult to palpate because of the subcutaneous edema as well as the weight gain that has occurred during pregnancy. All this adds to the difficulty in spinal. And complications related to central neuraxial blocks are also higher because the lordosis, the increasing lordosis also shifts the apex of thoracic kyphosis from T4 to T2. And in a lateral position, because of widening of the pelvis, there is a cephalic inclination of the vertebral column. So if appropriate correction is not employed during spinal anesthesia, we can land up with a high spinal. Coming to the epidural anesthesia, because of the engorgement of the vertebral venous plexus, what happens is there is unintentional intravascular injection. The hormones also causes softening of the ligaments, and this makes identification of the epidural space using loss of resistance technique difficult, and this can result in accidental dural puncture. The dose of spinal anesthetic in pregnant women is 25% less because of reduction in CSF volume because of the vertebral venous plexus distension. There is also enhanced neural sensitivity to the local anesthetic. This is a hormonal effect. And the increased intra-abdominal pressure also causes inward displacement of the intervertebral foraminal soft tissue. So coming to changes in the hematological system. Estrogen causes an activation of the renin-angiotensin-aldosterone mechanism and causes sodium and water retention. So by the end of first trimester itself, there is a 10% increase in the blood volume, and entirely contributed by the increase in plasma volume in the first trimester. In the second trimester, there is a rapid increase in blood volume to 30%, of which 25% is by the plasma volume and the rest is by the increase in the RBC volume. In this trimester, there is a secretion of erythropoietin as well as the erythropoietic effects of progesterone, HPL and prolactin that produces the increase in RBC volume. And a total, by the end of third trimester, there is a net gain in blood volume of around 45%, of which the plasma volume is 55 and the RBC is 30%. So this disproportional increase between the plasma volume and the RBC volume is responsible for the physiological anemia that is seen in pregnancy. So what do we achieve by this increase in plasma volume? Blood volume is 76 in a non-pregnant lady, while it becomes 94 ml per kg in a term pregnancy. That means we have a reserve of 1 to 1.5 liters available to meet the requirements during delivery. So hypervolemia is also going to cause dilution of the serum proteins. The total protein comes down and the albumin comes down. Along with this, the oncotic pressure, colloid osmotic pressure also reduces from 27 to 22 in the third trimester. One notable point is that the globulin actually increases, and this alters the albumin-globulin ratio in pregnant women. This decrease in blood viscosity because of a decrease in hematocrit and the colloid osmotic pressure is important because it facilitates better placental perfusion. Now, pregnancy is a hypercoagulable state. That means all procoagulant factors are going to increase, except there's a decrease in tissue plasminogen antecedent, factor 11, and fibrin stabilizing factor. Coming to the anticoagulants, actually they are either decreased or unchanged. So, corresponding changes in the TEC tracing is also seen in pregnant women. Coming to changes in the respiratory system, there's the enlargement of the uterus causes a cephalic displacement of the diaphragm into the thorax. It goes into the thorax by 4 centimeter, thereby decreasing the vertical length of the thoracic cage, and there's a widening of the lower thoracic cage. There's a 2 centimeter increase in both the anteroposterior as well as the lateral diameter, and the circumference increases by 5 to 7 centimeter. So this displacement into the thorax causes a decrease in the expiratory reserve volume as well as the residual volume. That means the functional residual capacity is going to come down, and it comes down by around 20%. Coming to the other volumes, there's an increase in tidal volume. This is to meet the metabolic demands of the growing baby, and the inspiratory reserve volume is also slightly increased by 5%. So corresponding changes we can note in the lung capacities also. Functional residual capacity we said comes down. One capacity which does not change is the vital capacity. Total lung capacity, there's a slight decrease because of a decrease in the functional residual capacity. The functional residual capacity returns to normal at 48 hours postpartum, indicating that it is a purely mechanical effect. Then FRC further decreases in supine position, but the closing volume does not change. This means that if the FRC falls below the closing volume, that can be airway closure that is occurring during tidal breathing itself, and we can land in hypoxemia. So following spinal anesthesia, it is always a necessity that we supplement oxygen. For general anesthesia, the safe apnea period, even after complete denitrogenation, is only as long as 2 to 3 minutes. So some simple maneuvers we can employ is by giving a 30-degree head-up position, which increases the FRC by 10%. We can either do it by ramping by using folded towels or by adjusting the OT table. This also facilitates easy insertion of the laryngoscope, because in pregnant women the breasts are enlarged and introduction of the laryngoscope plate may be extremely difficult. So as the metabolism increases, so is the requirement of oxygen, and the carbon dioxide has to be eliminated. The minute ventilation also increases to meet these requirements. Minute ventilation is a product of respiratory rate and tidal volume. The respiratory rate increase occurs early in the first trimester, and it increases by 15%. Although we call it 15%, if you look at the numbers, it is just an increase in respiratory rate of 1 to 2 breaths per minute. That's all. Beyond the first trimester, there's no further increase in respiratory rate. All the increase that occurs to meet the minute ventilation is the increase in tidal volume. So at term, the minute ventilation has increased by 50%, and there's a 40% increase in tidal volume. When comparing the alveolar ventilation and minute ventilation, actually the alveolar ventilation increases much higher. It is increasing by 70%. This is because of the decrease in the physiological dead space. So the increase in minute ventilation is perceived by many women as dyspnea. This physiological dyspnea has to be differentiated from pathological causes of dyspnea. Physiological dyspnea is generally gradual in onset, starts early in first trimester or the early second trimester. It is worse on sitting. It does not aggravate with exercise, and there is no wheeze or other added sounds. So hyperventilation is going to wash out the carbon dioxide. The carbon dioxide comes down by 10 millimeter mercury. The pH does not change much. It remains within the physiologic limits because of the compensatory changes in the bicarbonate. But the pH shifts towards the higher normal range towards the alkalotic side. And there is also a slight increase in the PaO2 levels. The decrease in PaCO2 is favorable because it facilitates the diffusion of carbon dioxide across the placenta from the fetus to the maternal blood along the diffusion gradient. The decrease in plasma bicarbonate, however, reduces the buffering capacity that is available during pregnancy. This decrease in FRC along with an increase in minute ventilation means that inhalation induction is going to be fast. Coming to the CVS changes, the apical impulse is shifted upwards to the fourth intercostal space and lateral to the mid-clavicular line. There's a 20% decrease in SVR in pregnant women. There's a fall in diastolic as well as the systolic blood pressure, but the diastolic pressure falls by 15% while the systolic pressure decreases only by 5%. That means the pulse pressure increases, and this is what we perceive as a bounding pulse in pregnant women. So cardiac output also increases to meet the demands. Cardiac output is a product of heart rate and the stroke volume. There is a 30% increase in cardiac output in the first trimester itself. By second trimester, it has increased to 50%, and it remains the same even in the third trimester. The next major increase occurs during labor. During labor, the contraction of the uterus is going to add additional volume into the central circulation. Along with this, there's an increased sympathetic activity that increases the heart rate as well as the contractility of the heart, thereby increasing the cardiac output further. The major increase that occurs is during the second stage of labor, where it increases around 110% above the pre-pregnant levels. So, beyond this, one more important thing that happens is after the delivery of the baby, that is immediate postpartum. There is a total contraction and the retraction of the uterus, which adds 350 ml to 500 ml into the circulation. And there's also a release of the IO2 cable compression. Because of all this, there's a rapid increase in blood volume and the cardiac output increases to above 150%. That means if we have begun with a cardiac output of 5 liters per minute, it increases to 7.5 liters in the third trimester. It increases to 10 liters per minute during the active phase, and immediate postpartum it can increase up to 12.5 liters per minute. So, the increase in cardiac output along with the decrease in SVR is what is responsible for the hyperdynamic circulatory state. The tachycardia and decrease in SVR is well tolerated in patients with regurgitant cardiac lesions but not in stenotic lesions. And patients with compensated cardiac disease may manifest it as failure at 32 weeks. And pulmonary edema can occur in the immediate postpartum period. The similar changes, whatever has happened in the cardiac output, can cause alterations when we are doing the CVS examination. Again, we may find flow murmurs and early systolic murmurs present, and it is important that we differentiate these physiologic flow murmurs from the pathologic murmurs. There are some characteristics of the placental perfusion. The placental perfusion is a low resistance circulation which has no autoregulation. Perfusion purely dependent on the arteriovenous pressure difference. Therefore, hypotension should be aggressively treated prior to delivery and targeting to reach the baseline levels. The uterine blood flow also increases from 100 ml per minute in a non-pregnant lady to 900 ml per minute at term pregnancy. And in case of atonicity, we can just imagine how much amount of blood loss is going to happen every minute that the uterus is going to remain atonic. So obstetric hemorrhage cannot be anticipated. Therefore, all pregnant patients should have blood grouping, RH typing, and blood reserved prior to taking up for cesarean section. The MAC decreases by 30 to 40% during pregnancy. This is because of the sedative effects of endorphins and progesterone, and it returns to normal at third day postpartum. There's also an increased sensitivity to the IV induction agents. In the GIT, the most important thing to remember is the lower esophageal barrier pressure is less, and this is because of the hormonal effect. The gastric acid secretion does not increase. Neither the pH actually decreases during pregnancy. But the proportion of women with gastric volume greater than 25 increases during labor because of the delayed emptying. So combined with the decrease in lower esophageal sphincter pressure, they are at high risk for aspiration. Changes in the renal system, because of the high cardiac output, the renal blood flow is high. Therefore, GFR is also high, and the serum creatinine normally in pregnant women is only 0.5 to 0.6 milligram per deciliter. The renal tubular threshold for glucose and amino acid also decreases. So minimal glycosuria and proteinuria of up to less than 300 milligram per deciliter is normal. To summarize, we have to thoroughly understand the anatomical and physiological changes that is occurring during pregnancy and their implication to conduct safe anesthesia to this group of patients. Thank you one and all for your patient hearing.